Hi, good morning, everyone. That's so rather apathetic. Good morning, everyone. All right. So, finish those emails, and for those of you online, we're back in focus here. My name is Asaf Bitan. I am a practicing primary care doc, executive director of Ariadne Labs, which is a health systems innovation center in Boston, and also a senior advisor at CMMI. But more importantly, for this panel and for the next 50 minutes or so, I'm your moderator and hopefully effective facilitator to let you hear and engage in the wisdom and with the wisdom of my co-panelists. And we're going to be talking about quality beyond measures, and we're going to be really focusing just to sort of level set on primary care and on what we mean by what works in primary care, what doesn't work, what challenges, but we're going to be solution focused. So there are a lot of challenges with primary care, and we could spend the next 2 weeks together talking about them, but it'd be more interesting to focus on solutions. And what we're going to try to do, and this isn't going to be one of those panels we've conspired and discussed beforehand. This isn't going to be one of those panels where we all tell you Captain Obvious sort of things and just politely agree and everything's aligned and works perfectly and let's go have lunch. We are going to be respectful, but we're going to try to sort of get to the next level on some critical issues around how to promote better quality through primary care, through aligned accountable care, through multi-payer action. And we want your questions, so it's not just going to be us talking at you. So get those questions ready, bundle them, and make them questions. If you want to go on a diatribe, maybe a really short diatribe. Questions. I'm just going to sort of try to level set for maybe 2 minutes on on a kind of fundamental issue we want to grapple with, which is that where we were 10 years ago, I just learned the land Summit is 9 years old. So where we were 10 years ago is not where we are now. And one of the main areas that's different is the fact that a lot of the question marks about whether there would be a kind of convergent definition of what we mean by advanced primary care, how we measure it. Is it generally the same thing, or is it a choose your own adventure? I think actually have been sort of answered in some respects. We have answers in a kind of amazing array of practices all over the country that are generally doing an aligned thing. They work with teams powered by data, caring for patients and communities, not just within the four walls of the clinic, and not just waiting for people to come into the clinic, but proactively reaching out. They are starting to integrate behavioral health needs and concerns in a variety of ways. They're starting to screen and meet social drivers of health. They're starting to integrate with sort of wider tenets of accountability and some levels even cost of care, while having gone through a pandemic, second highest mortality rate of any health providers, primary care, in general because of lack of PPE, payment models that don't often fit them, and a workforce crisis and burnout. So the interesting thing that we're going to grapple with is why there's sort of convergence here, but yet not enough progress. So we used to argue in these panels and in the country about, is there a medical home, and can you define it, and can you measure it? And now there's a convergence on overall definitions, and you have a National Academies of Sciences report in 2021 that sort of spare you the 449 pages. It basically says pay for teams to care for patients, not doctors to provide visits. Ensure that everyone has access to a primary care team in their locale. Train people in primary care where they live and work and will work. Ensure that IT meets people's needs, users' needs, and it's not just a billing platform. And make sure that there's an accountability structure for the pursuit and improvement of primary care across the US. And the reason for that clear report. And if you ever need the evidence, if you're sitting in your health plan or in your health system and you're like, someone says, I don't know, that primary care thing, I don't know how valuable it is, you send them that report and make them read 449 pages that suggest to you that the only part of the healthcare system, in which investments in it routinely and predictably result in better outcomes with more equity at sustainable costs is primary care. So quote that, look it up, send it around. It's true. Now, that's not to say that primary care is not the only thing you want to invest in. We're not getting into this, my service line's more important than your service line stuff. But if you're held to account in your job for improved outcomes, improved equity, stabilizing costs, I would present to you that you should be thinking very clearly on how to invest more, better, and differently in primary care, and make sure that the level, the type, and the flow of funds actually matches the primary care teams in their work. So if that's true, then what we're going to talk about is the negative, which is if we're convergently agreeing on a general care model and general principles of, paying for proactively for teams and multi-payer alignment and sort of all these things, then why isn't it happening? Or what are the challenges and the barriers? And, I'm really lucky to be joined in this panel by incredible folks. You should read their bios online. I'm just going to tell you who they are really quickly. To my left, immediately here, is Dr. Amy Scanlon, who's the Chief Medical Officer of Trinsic Clinically Integrated Network in Colorado. To her left is Dr. Therese Garrett, who is Behavioral Health Medical Director at WellCare Health Plans in North Carolina. Next to her is Eileen Testa, Administrator at 9th Street Internal Medicine Associates, one of the first level 3 medical homes in the country. And last but not least, Nick Minter, who's the Director of the Division of Advanced Primary Care at CMMI within CMS. So that's my intro. First question for our panelists is really, if we have this convergence, we know what the facilitators of good primary care look like in general sense. We know that primary care is important. So in what areas in your work are you seeing alignment and convergence across providers and payers in this area? And in what area are you feeling the incongruity or the challenges, and where we have further to go to make this a reality? So anybody want to start, or we can start?
Yeah, can everybody hear me? I think a couple of things. So especially in my work, I work in what I call the in-between space, which is between primary care visits. And we try as hard as we can to bring care resources to that space to help patients in between their visits. So I think that's one area of opportunity to really start to structure payment models that account for that space. So we have huddles. We bring virtual care huddles that we huddle with our primary care doctors on a regular basis about their patients, asking them what they need, how can we help, what resources can we bring to the table. So that's an area where there's an opportunity for convergence. Areas where we find real barriers often are in quality measurement. We all want to measure quality. Quality is super important, but everybody has their little way of doing it. And so we as a network, for example, we have contracts with all of the major payers, and we are part of the MSSP program. We are accountable for about 130 different quality measures, and what we try and do is condense those down for our doctors in the form of a single scorecard. So those are the two areas that we work in.
Thanks so much.
So I would say where there does seem to be significant alignment is in looking at the fact that we do need to be using alternative payment models and the ways in which fee-for-service isn't getting us where we need to be, both in primary care as well as in behavioral health, so that we can shift from this, let's have doctors see as many patients as they can, as many in a day, in order to be making the money, to be looking at how are we best caring for our patients. And I know we saw a lot of some of the places where fee-for-service doesn't work in the pandemic. And I know in North Carolina more recently, we've seen where fee-for-service isn't working with some of what's happened post-Helene. Because with Hurricane Helene, a large number of our practices out in Western North Carolina were closed down for a period of time, either because their places were damaged, there was no power, no water, or they couldn't get there. Yet during this time, the wonderful practices have been doing all kinds of outreach. Some of them have been going out to the homes of patients to bring them their medication. Some of them have been going out to check on them. All these things that don't fit into our fee-for-service CPT model of care. And if we across time are able to see like, hey, how can we actually be incentivizing folks providing the kind of care that's in these in-between spaces, then I think we have the opportunity to be moving forward. I would agree in terms of some of the, what does it look like in terms of quality measures and how do we get those across? I think in an ideal world, which doesn't exist, all of this stuff would happen and would just magically, through the ether, get from one side to the other. But that's not how it happens. And so I don't know what this is going to look like because I'm not a data person, but my hope is that as things move forward, with some of the LLMs and AI, that we'll be able to better extract information in a way that takes some of the burden off of practices as we're trying to get some of that across. And I know within North Carolina Medicaid, from the beginning of our Medicaid transformation, they recognized the need for there to be similar quality measures across plans. And so we have an advanced medical home measure set that is the same for all of the Medicaid plans so that our practices aren't needing to look at 20 for well care, 20 for one of the other plans, 25 for another, et cetera.
It seems hard to imagine that the sort of shared goals of this 10 plus 15-year endeavor can be met without really hard choices on sort of parsimonious measure sets that aren't perfect and no one's fully happy about, but allow focus to change the things that should be changed and time to focus on the interstitium. Eileen.
I also think that there needs to be the ability to allow practices that are at the highest level of their measures, not to punish them or say, well, you still have to show levels of improvement year over year, because sometimes that's not sustainable. We have, for example, for colorectal cancer screening, our practice is at 90% for all of cross payers. So where do we go from there? How do I get to 100%? That's not going to happen. We're not going to get 100% compliance. So, but I have to show improvement from all of my payers. How do I do that? So there has to be some sort of limits to say, well, you're a top performing practice. Kudos to you, let's move on to the next thing, or what else can we show improvement? But our ADK is terrific, and our EDK is great, and our other measures are great. All across the board, yes, there's some things that we do have to work on, but we're not 100% perfect everywhere, no one is, but we're good. So, but the problem is, and I sort of said this before when we were chatting a little bit, is that there's a lot of low-hanging fruit in these payer mixes where you're part of these value-based care contracts, and there's a lot of groups and practices that are at the bottom tier of these value-based contracts, and they are not performing at all, and their value is just dragging everybody else down. So what do you do in these cases? Somebody has to say, we're going to limit what you can do. We're going to say to you, you've got 3 months, 6 months, or a year to get your act together, or we're going to drop you out of the contract. I don't know if that's a good thing, but if everything is going away from fee-for-service, what happens to these practices that refuse to participate and refuse to do anything with quality measures? What happens then?
Well, Nick, you have a lot of experience incenting, cajoling, encouraging, bringing together lots of practices in the work of the advanced primary care models. Some thoughts on your end?
I mean, Eileen, I think it's asking great questions, to be honest with you. And we think a lot about, just to note, we think a lot about sort of how to bring practices along that aren't, that's where there's the most room for improvement. So there is some sort of logical truth to that. However, I think part of what you're describing is sort of a problem I wish we could deal with more, which is like when our performers are at the, sort of at the apex of what's achievable, how do we continue to sustain that? think it's a fair point to bring up and something that we need to think more about. Wanted to sort of contribute to the broader discussion too. I think two things that we're seeing progress on, I don't know that I would necessarily say that we're where we want to be or working well, are sort of quality measurement alignment. I think we do see progress there. And some of the progress, certainly within the models that I have the pleasure to work on, which are advanced primary care models, but even independent of some of the work CMS is doing. And in states on both coasts, we see that there are collaboratives where payers are working together to agree on what those outcomes should be. And that reduces provider burden, that helps drive preventive outcomes that we all know matter clinically. And I think rewarding providers for achieving those outcomes, totally acknowledging that it's not perfect, but we've seen movement over time in the right direction to acknowledge and that we need to pay more for some of those preventive progress, if you will, in terms of making patients healthier. Where I actually think we still have a long way to go, however, is in prospective payment. For primary care, it's interesting, Dr. Garrett, you were just talking about some of the real advantages there. And that's something that we saw during the pandemic when we were testing Comprehensive Primary Care Plus, as well as sort of getting primary care first off the ground, that the resiliency that sort of prospective payment brings is really important because things happen at the practice level day to day. And it is those independent primary care providers, those that I think have a really strong connection to their community and a fidelity to keeping their patients healthy that are the most vulnerable to those sorts of disruptions. And I think that that's difficult. I think it's difficult technologically for CMS, certainly, to acknowledge that we struggle with this too, but also payers to figure out how to move away from fee-for-service and pay primary care, not total cost of care, not to look at the whole book of business, but to sort of parse that out and pay that prospectively is difficult. And I think it forces us to come to terms with questions like, well, how do we deal with potential abuse? Is that something that is okay? I mean, in a way, I think we certainly struggle with that, but no, I think our models have availed that, the perfect can't be the enemy of the good. We need to have safeguards in place, but it is really important to provide the resiliency to the backbone, I think, of the healthcare continuum to be able to subsist and to focus more on patient care, because all of this does what I think we're saying is most important, which is removing boundaries between the provider and patient care.
I think these have been really, really important points, and I think that sometimes in the discussion of the LAN or discussion of sort of value-based care or BBC conferences and knowledge products in general, this issue that Nick raised is kind of given quick turnover. Like, it is really hard, and I'm saying this not from a payer perspective, but it is really hard for a payer to recode the way they pay for a key part of the health system that they have been paying for 50 plus years. Now, it's really hard, but listen to the next part. It is possible. Okay? So, you don't get credit for things being hard as a reason not to do them. That should be taken into account. It took 3-4 years, I would say, at the minimum at CMS to recode this stuff. People are not used to paying prospectively and proactively. There is a question of the 2% bad apples. What if they abscond with the money and don't do what they say? Would just remind people, you don't design systems based on the 2% of people who act badly. You build safeguards for those 2%, and then you take the 98% and you sort of try to use as incentives. But it takes time, and it's possible. And speaking of possible things, so Dr. Scanlon, Trinsic is a really interesting new clinically integrated network, number of provider units coming together with the goal of delivering better health, through this integration. Can you talk about an example where this integration is providing and how it's providing higher value and sort of encompassing some of these principles?
Yeah, and I want to say the issue of prospective funds is huge. So our network is comprised of 2 giant health systems. About 50% of the doctors in our network are actually employed by large medical groups. We have an academic medical center that's part of it, and we have large independent practices, and we have Dr. Chris Villapanto in Pueblo, Colorado, with his 1 MA. So we have a really wide variety of practice types, all primary care. And what we bring to the table as a network, we have contracts with all of the major payers in Colorado right now, and we're part of the MSSP program. And Medicaid is one area that we're not working with currently, but a lot of the commercial payers have stepped up and provided care, what they call care coordination fees, which are prospective fees. And that's allowed us, along with the investment from our owners, the two major health systems, to provide care huddles. So we have virtual care huddles that we've put in place that consist of a care coordinator and a care manager. And then behind those two people, there's a team of pharmacy and social work and other people, data analytics, finance people that help build those teams. But the physicians with our value-based panels, they huddle with these care coordinators and care managers pretty much every week. And we are responsible for bringing to them the patients that need to be surfaced, that maybe they aren't aware of, coming out of the hospital, coming out of a SNF, coming out of an ED, also patients with care gaps, new patients who haven't seen a primary care doctor in a long time. So the huddles are really, a lot of people do these huddles. The payers often will have resources that patients have available. We can connect to the payers to bring those resources as close to the patient and the physician as possible. We really want to make sure this kind of work happens as close to the patient as possible. And oftentimes, though these programs exist, they are often 3 or 4 times removed from that place. So we're trying to bring all those resources to the actual provider-patient intersection. So, and it's been really, we've gotten some great feedback from the physicians we work with. We're trying very hard to deal with burnout and make sure that we're not adding to their plate, that we're really bringing stuff that's helpful. But it's been pretty successful, so.
Just a super quick follow-up, sometimes it's hard for clinicians to get out of fee-for-service treadmill mindset. Like you say, we're bringing these teams together and we want to meet with you on who's not here today and who's just out of the hospital. And I've seen many people say, I don't have time for that because I've got to churn visits. So how have you addressed that?
Yeah, we did have some pushback, and we still continue to have some pushback about, I don't have time for that. We really have been very clear with our practices about this has to happen for the first 3 months. After that, if it's really not valuable, come talk to us. But a lot of it is about building that trust. And we've been really clear with our teams about they have to show follow-up. So when a provider says to them, I need this done, somebody has to come back the next meeting and say, here's what I did. And really developing that relationship, that trusting piece is super, super important. But it is a work in progress. And so, it's because these huddles bring different value for different practices, so.
And maybe building on that, Eileen, your practice is like I want to sort of give you the props that it's kind of a historic marker, both in performance and trailblazer. I mean, if you want to learn your practice was doing a lot of the stuff that we take as sort of conventional wisdom way before it was. And that's a journey. And so I guess from your perspective, how has your care delivery model evolved over time to sort of make normal what is challenging, that we just heard described, where you make huddles and proactive risk stratified care management kind of the norm and not the exception?
Well, back in 2006, 2007, when we started the process to become a patient-centered medical home, this was foreign to us. I had never heard the word HEDIS before in my life. And I kept looking at people going, what are we doing? Are you sure you want me to do this? It was one of those type things. And I had been in healthcare for longer than most of you have been alive, so we'll just cross that bridge. But it was really very interesting to see where we started. And I will tell you, I think the biggest challenge was doing all of the measures by hand, counting every stinking thing manually and putting it on an Excel spreadsheet, which I think it was not even Excel back then, it was the other thing. I can't even remember what it was called. But doing that every single month to see where we were statistically for all of at that time, we were 10 providers. We are now 16. And doing that continuously every month for every measure, because our EMR was not up to par. Basically, our EMR was schedule appointments, you can do things in the progress note, and you can run reports and you can do billing, but that was about it. And it didn't have anything. And we kept saying to them, you have to get on board with this. And I think that was a huge challenge, but we came through that. And we hired a care manager because we realized that we needed somebody to do that. We needed to have somebody take care of our critically ill patients and monitor them. And calling our patients after discharge and going over and doing med reconciliations was huge. Our 30-day readmits dropped 100% in the course of a short amount of time because we were talking with them and going over things. We had patients with congestive heart failure, and our care manager would speak with them every day talking about their weight. And if their weight went up, she would monitor the next day. And if it went up another pound, Lasix would be added. And we had standing orders, so she was allowed to do this. And it worked out perfectly. We stopped those patients from going back into the hospital. So all of this, having the drive to do this changed the way we practice medicine in the office. And it was drastic. And our patients felt differently about it. Our providers felt differently about it. I'm sure you saw that in your groups, where you just see the relationships change. And the doctors would say to the patients, this is important for your health that I want you to have this done. I'm not just being a pain asking you to go get these screenings. This is vital for your health. And then the patients would do it. Or our nurses, I made a decision probably about 10, 12 years ago to not hire, and I'm not disparaging anybody here, but to not hire medical assistants any longer, because I felt like the people coming out of school were just not up to par with what I needed. And we hired LPNs, and each LPN is assigned to a provider, and they work on a one-to-one basis. And they do all the chart prep, and they go get the records beforehand, which is a whole other issue I'll get to. And they would get everything necessary, and they go into the room and they do a med reconciliation, they would do the orders, they'd give the injections, they do everything that's necessary. And if it's a sick visit, they do whatever testing is necessary and capable at that moment, so that when the provider walks in, they've got everything in their hand when they walk into the room. So this also alleviated a lot of the stress and pressure from the physician and our nurse practitioners. We have some advanced nurse practitioners. But what we found is that it changed everything for the better in our group. And our visits may have been, the same amount of time, but the quality of the time spent with each patient was valuable.
Can I add one thing? Both she and I, we've been talking about bringing this kind of proactive approach as close to the patient as possible. And I want to just call out, there are many companies in here and payers in here that have care management programs that are associated with the plan. And I think those programs are great, but they're a level removed. And oftentimes what we find is they don't reach the patient in the same way that it does if you're in the office, or if you've got a care manager that's associated with the actual clinic calling, those kinds of things. So I think in terms of prospective payments, like the payment model has to get down to the ground.
Yeah, it's not enough just to change the form or increase the level. Actually, the flow has to reach the teams that are being built to do this work.
And the payments have to come in more regularly. They can't come in a lump sum one time a year. You can't budget that way. It's just impossible.
So one of the ways that care management works in North Carolina Medicaid is most of the care management is delegated to the advanced medical homes. It's about 80% of the care management that is delegated to the advanced medical homes that are doing the care management and are getting fees monthly for the care management, which allows for that local feel, allows for some of the folks that have had historical relationships with the patients to be able to continue to do that. And from the payer side, what we're doing is then meeting with each of the AMHs on a monthly basis with the care management teams to go through some of the data that we might have that they may not have. And then we also are meeting with them quarterly to go through some of the scorecards, looking at where they're at with different metrics and how they compare to comparable practices. So we'll show the AMHs that are primarily pediatric, how they compare to other pediatric practices, and the ones that are family medicine and sort of the full age spectrum, how they're comparing to other practices. And they're not seeing like which other practices, they're just seeing it like A through G as the others. But then we can be looking at the AMH level about, is this an advanced medical home where we're seeing more pediatric ER visits than another AMH? And if so, why is that? Are there not urgent cares in that setting? Are there need for other kinds of opportunities? Is there a need for telehealth that's different in that area? Could the clinic be open at a different couple hours here or there? What are some of those things? And we've been able to make some significant movement with the AMHs, and I think has been really valuable also for some of the smaller advanced medical homes that don't necessarily have the ability to run some of that data as well.
Dr. Garrett, I wanted to follow up with you on another area of sort of building on this place-based versus from a distance. So you've led a lot of incredible work on behavioral health integration, pediatric, adult. And one of the things that when we talked about that I think is worth mining a little bit more is, do we have an integrated view of what we mean by behavioral health integration? Like, are we all speaking the same language here? And if not, then where are some areas to sort of sharpen up and better incentivize a kind of aligned view of that?
Yeah, I mean, I think that we are speaking the same language. I don't know if it's exactly the language that we need to be speaking. So oftentimes when we're talking about behavioral health integration, we're talking solely about integrating behavioral health into primary care settings, with bringing a behavioral health provider into a primary care setting, with putting collaborative care into primary care settings, all of which are excellent things. And for many people, their primary care office is their medical home. And then there are also folks with serious mental illness, youth with serious emotional disturbance, others who are very strongly connected to their behavioral health clinics, for which the behavioral health clinic really is the primary home. And I would like to see behavioral health integration really be something that's bidirectional, so that we're also looking at folks for whom the behavioral health setting is their primary care location, to be bringing in some of the physical health services into those areas. Part of that is going to be putting the brain and the body back together and making sure both sides feel comfortable in talking about the other. Oftentimes, whether you're on the physical health side, there can be discomfort with certain aspects of behavioral health or SUD. And I see similar things in some behavioral health settings where there may be extreme discomfort in asking questions at all, even about, does this person have hypertension, or does this person have diabetes? And so part of how we're also working to manage that is working with our physical health providers around education, around behavioral health and substance use disorders. We've done some trainings for our local health departments on perinatal substance use disorders and supports for both birthing parents as well as infants. And then we've also done some work in other settings in working with behavioral health providers around understanding various aspects of medical and physical health care, whether that's through trainings about common illnesses, or whether that's through talking about things like, what does reproductive health discussions look like in behavioral health settings, since oftentimes if somebody's getting therapy, they're coming in every week and they're going to see the therapist sooner from a sexual assault or unprotected sex or other sorts of things.
So my next question is for Nick, but after that, we're going to transition to your questions. So think about them, make them short, so we can get a good round of them. So Nick, you've been a key leader at this center, the Innovation Center at CMS, through this journey toward and toward advanced primary care models that meet different parts of the market. Do you see a convergence, sort of core features of what advanced primary care is starting to look like from CMMI's perspective, and B, what are they, and how do you keep moving forward toward them?
Yeah, it's a great question. And first off, I'll start off by saying, I mean, I think you're too kind. I think I get to play a key role, perhaps, in some of the work we've done, but primary care has been a key driver across the entire continuum of innovation center models that we really test. Certainly in the advanced primary care models that I have the pleasure of working on, but also I think as studies have shown, and we know that primary care is really a driver of success in our ACO models, like ACO REAP, Medicare Shared Savings Program, which is over in the center, I mean, is also spanning over into the normal Medicare program. But also in our state-based models like AHEAD and the Medicare Primary Care Program, which are investing in primary care at that state level. And I think what we have seen is there is a convergence over time. Just as an example, when we started testing the Comprehensive Primary Care Initiative in 2012, we really built upon what were already starting to emerge as some recognized advanced primary care components. My mic is telling me I should stop talking, but I'll keep going. So things like access and continuity, planned care for chronic conditions, risk stratified care management, patient and caregiver engagement, and coordination of care. We learned a lot in those first 4 years. We added behavioral health integration, real focus on that, I think, above and beyond when we tested Comprehensive Primary Care Plus starting in 2016. As we moved into primary care first, based on continued feedback from our participants, from both at the provider and the patient advocacy level, we also added advanced care planning as another component that's really important. And to something that I did want to call out, we also allowed more flexibility in how some of these care, what we would call care delivery requirements were met. I mean, we typically in our models fund, the advanced primary care model specifically, sort of give payments to practices above and beyond care coordination-like payments, and we say, here's what you need to do. We learned in primary care first, there are practices in regions where care is not going to look the same as another place. Or in the case of, to call out Eileen, like 9th Street's been doing it a long time. We don't need to tell them how to do it. We need to give them flexibility. And so we added that in primary care first, and we had the benefit in making care primary of building upon the National Academies report that you already referenced, Asaf. And so one of the things we tried to do there is reorganize our care delivery requirements into 3 domains. Care management, care integration to include behavioral health, as well as specialty integration to keep primary care sort of at the center of all those interactions, as well as community connections, acknowledging that if we're going to really provide person-focused care, then we need to have community referrals to help address a lot of the environmental factors that can't be addressed in the waiting room, or excuse me, in the examination room. And so I think we've seen those emerge. We're still evolving, we're still testing, but I think that focusing on those has been successful. CBC Plus is the most recent model, I should say, in my realm that has been fully evaluated. And while at a national level, it didn't necessarily meet our stringent requirements for expansion, there have been several regional studies that have shown that it has produced both quality improvements and care savings. And I think that's because we've been very focused at bringing payers together, both to support our models generally, which has been a big benefit of working with the LAN over time and of you all, but also focusing on some of the care delivery practices that we know and have a long track record that I mentioned before and that we've added to over time based on where the industry has gone.
Thanks so much. So now time to hear your questions. We're going to take them in pairs of 2. Hopefully there'll be at least 2. Otherwise, I got lots of questions for them, but maybe you do. Keep them short and focused. Tell us who you are. And again, we'll do 2 questions, and then whoever on the panel wants to take them, that's great. I can't see you, so go ahead and introduce yourself.
That's an interesting challenge. Okay. Bill Golden, Arkansas Medicaid, running the medical home program since the CMMI in 2012. Just to respond briefly to Eileen Testa's comment, we've actually put in place penalties for laggards in quality measures, and they get very responsive, and the community has supported that. But one of the things that my question is, people often ask about these alternative models and to show return on investment, but in reality, you're creating a new product. So can you do some reflection on the fact that perhaps this evaluation is misguided because you're not comparing traditional primary care. It's really a different way of providing primary care, which should change your return on investment equation.
Great, we're gonna take one more question. There's an ROI eval question that's right there to be answered, and then, yes, please.
Hi, I'm Rob Chamberlain. I'm from Maine Health, and I help lead our primary care group there. And my question is around investments in primary care. So when we invest in primary care, we think mostly investing in the care team. So we invest in ambulatory pharmacists to do post-discharge medrec, and we have a virtual team to offer same-day care, nurse practitioners to help with your panel size. And what I'm hearing more and more from my PCPs is all that investment just destroys my continuity with my patients. If you want investment, give me smaller panels and more time, and that investment is really expensive, and it would massively decrease access in the community to primary care. So could you talk about how you think about investment, and specifically in relationship to the continuity of care with the primary care physician?
Great, so who wants to take the ROI eval and who wants to take the investments in continuity question?
I'm happy to start on the ROI question, which, Dr. Golden, I think you make a phenomenal point. And one of the things that we have learned and I think put into practice in our primary care models, if you look at the entire time span from CPCI, which was a 4-year model, just as the Innovation Center was getting out the first Conference of Primary Care model, we learned then and have learned since that putting money into the ground in primary care does take time to return. Some of this is very clinically based and seems obvious when you say it out loud, but if we improve blood pressure today, that doesn't necessarily mean we're going to prevent a heart attack in 2-3 years, which is when we need to know if a model is going to be successful. So in Making Care Primary, we're testing that model over the course of 10 years, because that gives us a longer window. There are still some challenges, I think, that are hard to overcome. Our evaluations of the Innovation Center, which are integral to the scalability of our models, are actuarially based. They are very statistically sound, but they can't capture some things. For example, there are a lot of spillover effects that come out of our model, and one of the things that is very unique to Medicare that I like to tell people a lot, so this is my soapbox, is that we are unique in that a lot of the payers that are in other practices that we are touching indirectly, they all end up becoming Medicare patients, and so if they come in healthier, it would be really nice if we had a way to capture that value, but we don't currently. The resiliency, which I spoke to earlier, of independent primary care practitioners, we don't have a good statistical method to say, well, what is the value of keeping them in business and keeping those relationships strong, knowing the accountability there is different than if everyone's employed in a different sort of scenario. And I think those are challenges we're still thinking through and still working on, but at least we know they exist. Pass it back.
Continuity eval lightning round, and we'll get more questions
I
shortly.
can take the continuity a little bit. We've looked in the 2 systems that I work with, we've also run up against this, really what we want are smaller panels and more time with our patients, and I think it's the right question. I actually think it's unfortunate that we as primary care doctors are held to what I call the tyranny of the 20-minute visit, because it's really hard to do that work in just 20 minutes, even with a support team around you. And I understand the access issues. And so I think the question often becomes, are we doing the right care in those visits? And really thinking hard about what is the right care to happen between that doctor and that patient, and what is not the right care. Sometimes signing forms is the right care, because it really is part of that relationship, and having the conversations around those forms may be helpful. Sometimes somebody else should be checking the blood pressure. That somebody else probably should be part of the team, but maybe it doesn't have to be you. So I do think sort of really rethinking and being very diligent about, am I doing the right care for the right patient at the right time, is really important as we move towards these models.
Sometimes the best thing I do in practice on a given day is help someone keep their lights or heat on. So one from there and one from there. And again, quick questions, quick answers, so we can get everyone's voices heard.
Hi, everybody. I'm Liz Casper. I'm with North Carolina Medicaid. I lead a lot of our value-based payment work. I'm curious to hear the panel's reflections on something I feel like we encounter a lot at Medicaid, and this, I think other people probably encounter this too, and that's the kind of clash of aspirations versus reality on the ground. Dr. Garrett spoke to, in North Carolina Medicaid, we have a delegated care management system in our advanced medical homes. We have a standard measure set for our advanced medical homes. What we hear about lots and lots is from providers, the assignment isn't right, or we have 1 million payers. We have several Medicaid managed care plans. That's just Medicaid. They also serve other patients from other payers. They get a per member per month that's supposed to come monthly. As Eileen said, that can't be annual. That's great. There's concern, how do I check I'm getting the money? I think just that provider abrasion, the administrative burden, just the reality of kind of translating these programs to the ground. I'm just curious for reflections on ways you've had successes, or just ways to think about doing things in a way that really helps what we're trying to get to and doesn't just leave a huge disconnect between our design and kind of what's actually happening.
Great. And one question from this side?
Can you hear me? Yes, my name's Tom Eichelhart. Some years ago, I helped organize a care innovation seminar with Dr. Alan Gorel, professor of primary care at Harvard. And one of the themes that he returned to regularly was the difficulty in the short time they have with patients is for primary care doctors to find out what's really going on in the lives of their patients. And I'm wondering if you see that, if that problem could be solved, if you see ROI in that, like a patient self-reporting mechanism that might increase the physician's knowledge without a lot of effort.
Great. So we have the aspiration reality and patients doing more self-reporting on what matters most.
So I'll actually take, I think that last question. I mean, I could talk about what Liz brought up about the reality versus aspiration, but Liz probably hears from us plenty. When thinking about some of the patient reporting options, there are, mostly so far within behavioral health, a variety of quality of life kinds of surveys and evidence-based tools that can be used. They're not as commonly used. Mostly, obviously, what we're seeing used are PHQ-2 or PHQ-9 and GAD-7, which tells you something, but honestly, it might tell you that the person got cut off on the way into the appointment this morning and they couldn't find a parking spot. And so they're really frustrated in this moment, but they're actually not clinically depressed or clinically anxious. And so there are some tools that can be used to be starting to look at some of this. One of the concerns I have with any of these tools is most of them are requiring digital access, whether, if you get a reminder appointment, a reminder text on your phone saying, hey, check in for your appointment tomorrow, go online, fill out all this stuff. You can only do that if you've got a smartphone and internet access and all these other things. So are we then continuing to feed into disparities if the folks who are able to get that information for you, Dr. Scanlon, are the folks like me who actually are able to do this versus somebody who's in a rural community and they weren't able to pay their phone bill and so they didn't have that access. So then you're spending your 20 minutes with them trying to ask the questions that you already have information from me on. And I don't have a great solution for that one, but I think that that's one of the pieces that as we're looking at all of these solutions, especially in the digital health space, trying to think about how can we do so in a way that is not going to further the disparities that already exist.
But having the patient self-report has really been dynamic lately because of social determinants. We weren't asking those questions years ago. Now we're getting that information that we can actually help our patients.
Yeah. I'm going to have to take, sadly, the moderator's prerogative because we are at time. I really apologize. I'm sure the panelists would love to speak with you afterward. And we didn't answer the question about aspirations versus reality, but in many ways, that's the meta question of this panel. Because I think that the aspiration and the alignment, at least conceptually, is clear. I think most people in this room probably agree that a high quality, better paid, high powered primary care system that does the things that the panelists talked about is what the country needs and what your communities needs. And yet, very, very few people are able to do this on a daily basis. And we have to face the elephant in the room, which is that primary care workforce is in deep, deep trouble, both on the inflow and the outflow. And that's not just burnout, that's a whole bunch of things. So I think that pushes us in the rest of the conversations. If you agree that primary care is important, it can't stay in a conceptual level. Like, primary care is not some theoretical nice thing in the clouds. It's not a fuzzy bunny to, oh, they're so cute and friendly and nice, and maybe we'll throw them some scraps. If you want better outcomes with better equity at a reasonable price, you double primary care spend. Is that easy for you to do? No. Is that easy for you in your health system with all the other issues to do and find and hire and train the right people? No. But look what happens when you do that. And look what happens, and if you're wondering whether CMS is interested in that, look at the work of the teams and of the strategy plan that has primary care not as an afterthought, not as but as a foundation. And so that's maybe that critical aspiration to reality is making it not just, it's like motivational interviewing or organizational behavior change. You have to make it something that you roll with every day and you push every day, not just some days. The final thing I would say is that it would seem then that, as Churchill once said about something very different, this is not the end. It's not even the beginning. It's not even the beginning of the end. It's the end of the beginning in terms of this story about whether primary care gets to where it needs to be or whether it keeps fragmenting and just sort of puddling along, honestly. That's up to you in large part, and your commitment to fund it, to push for it, to make it viable, to make it tenable. With that, I want to remind you that the alignment landscape was released by the HCPLAN, and there's a web-based tool outside that allows you to explore primary care and how it intersects in that landscape. I want to thank all of the panelists for their time, wisdom, and for joining us. Please fill out the QR code survey on whether this was useful and provocative for you. And I am told that the afternoon starts at 1:40 sharp. We are making up lost time by eating into your lunchtime. Sorry about that. Thank you for joining us.